the year in progress in VCID. I think that's a really good thing to think about. There are two answers. I think the big news this year has been the licensing of Aducanumab for AD, for Alzheimer's, and that's had so much media attention. I don't think I need to add to it particularly. Who knows how that will end up? Who knows how the whole field of anti-amyloid antibodies will end up? What it does do is generate a lot more patient data that can potentially be used for other treatment approaches. So the one I'm most interested in is vascular treatment targets. We'll get a great deal of patient data, including vascular data, on the people who take aducanumab. And I think there's a sense that there's something of an open field here for other ideas in treating dementia and related cognitive disease, adult cognitive disorders. So I sort of come away from that feeling, if someone has a good idea for a dementia treatment, this is not such a bad time for them to be refining their idea, talking to any clinicians they know about how that would work in the real world, talking to any drug company colleagues they might know about how it could possibly be marketed, and putting together a package. That's certainly what I would wish to do, and I would encourage any colleagues worldwide who are thinking in this space to do the same. We in the UK have a network called Dementia's Platform UK that is designed to filter such good ideas and try and get them to a commercial partner, get them to the point of being de-risked where a company might consider them. I lead the vascular theme within Dementia's Platform UK. You can find it on the internet. I do encourage anyone who watches this, if they've got a good idea, do feel free to get in touch. So that's one answer. The second answer is, within the vascular space, we increasingly are aware that blood pressure lowering seems to work. The evidence for that is growing. The quite a famous trial was the Sprint Mind trial. It reported in 2019, but the papers are still coming out. And to remind you, the Sprint Mind trial suggested that intensive blood pressure lowering to below the guideline recommendations, to specifically to 120 millimeters of mercury systolic blood pressure as a target, reduced risk of mild cognitive impairment and a reduced risk of a so-called combined endpoint of MCI and dementia. And that doesn't often happen, where a trial comes along that has shown such a robust signal. Now, the other message that I took away from the AAIC conference in San Diego was a report from Ruth Peters, who is at the University of New South Wales in Sydney. And what she had done was take all the data from 5 big clinical trials, big blinded trials, and do a single participant meta-analysis, which must be a great deal of work. And the combined cohort was 28,000 subjects. And all of these had been blood pressure lowering trials. And her simple question was, does lowering blood pressure influence risk of dementia? And she came out with a significant finding that it does. It's messy data because it's combining 5 different trials, each with a slightly different design, but the change in risk is significant, and it was about a 13% reduction overall, which is not huge. 13% reduction in your risk of getting a cognitive disorder, but that's actually not bad. We can build on that if we could refine the intervention a bit better. That seems like a foundation. It supports the sprint mind finding, and it seems like a good way to go. In other words, late life, intensive blood pressure lowering. Doesn't matter what drug, just get the blood pressure down.